Hey, OT practitioners, do you have a hard time finding your goniometer in that cluttered bag? Tired of digging and dumping your therapy tools in front of clients to find what you're looking for? Sick of carrying a medical bag that looks like a 1970s lunchbox? Well, then you need a Clinitote. Clinitote is a high-quality medical bag that is functional and fashionable. The perfect pockets for finding your important OT tools, made of a hygienic material, and has over-the-door hooks. You can hang that bag, keeping it off the floor. Get 30% off your Clinitote bag by going to www.clinitote.com. That's CLINITOTE.com and use my discount code SFPodcast30.
Welcome to the Seniors Flourish Podcast, where it's all about helping occupational therapy practitioners disrupt the norm by throwing away the rainbow art and being the best you can be when working with older adults.
You know when you have those patients that don't want to put up handrails on the stairs or outside the house because they're afraid it'll make the house look ugly or make the patient look, quote, old? Well, I found these handrails from Promenaid that are super stylish, come in all sorts of finishes and colors to match any type of house. I like that they're super adjustable and you can literally put them anywhere, even those funky corners where the patient needs something but nothing ever quite fits. They ship quick and be installed right away, so we can adapt the home to what our patient needs fast, which is our number one priority. Check them out at Promenaid.com, Promenaid.com. Welcome everyone to the Seniors Flourish Podcast, speaking of OT, Betweenisode. I'm Mandy Chamberlain.
And I'm Sarah Stromsdorfer, and we are occupational therapists, and today we are talking about occupational therapy and its role in mental health.
Mental health. I don't know about you, but I've never worked in strictly mental health. Have you, Sarah?
No, I've never actually worked in it. I did have a field work.
I had a field work too. My field work was in a forensic behavioral unit in Wisconsin State Mental. They called it at the time mental hospital, I think. They probably changed to something a little bit more PC. But it was very, it was like an institution, and they had, it was big, and it's been a long time, but it was like one of those field works where it was one of the most influential, it changed how I felt about mental health. Like I always felt like I was kind of like this open person about, criminals and forensics and all these different things. And then I went there and it just like turned my life upside down because most of the patients that were there, they had they went through the court system, and instead of going to, quote, jail, they went to this mental health facility. There was one guy that was there for like 20 years.
Wow.
Like a really long time. And it was all sorts of things from like murder to like pedophiles to like not even exaggerating, one of the patients that was there, because they were all long term. A lot of them were getting ready to transition into the community. So that was part of our job, life skills and getting them ready, and they had schizophrenia and all sorts of things. And one lady was like a professor.
Really?
She was a professor like at a university, and she had schizophrenia, and then she attacked her roommate with a fork, trying to there's just, it's one of those ones where this is almost like, I always felt like it was like stories that didn't even feel like they were real.
Yeah.
But it was really such an experience for me, and just humanizing people, I think, a bit for me, because it was such, but the whole thing.
So eye-opening.
Yeah. And it was like, we had the buzzers and it was the whole shebang, because it had like medium and moderate security. And it was one of those, like, because my personality is like, I'm very kind of upbeat, and I'm trying to describe myself, I guess. I'm upbeat, and I go... Yeah, I kind of just go with the flow. But the thing about it is I totally fine-tuned therapeutic use of self, and like matching the patient's energies. I had to go in there with confidence, and like I remember, prepping myself like I'm going in there confident, and it just turned into this. It was more personal, and really what was my role there. It was an amazing experience. And like at the time my CI was retiring, and everybody's like, you should stay. And I felt proud of myself because I was so scared at the beginning, just trying to figure out my own bias. But it was an awesome experience. What kind of, you said you didn't work in mental health, but you had a field work as well.
Yeah, my mental health. And I feel like every mental health field work and work experience, it really does open your eyes so much, because mine was in, it was a homeless shelter, a homeless apartment complex called a Housing First model in Atlanta. So they take adults with mental illness, and they did accept people that use drugs because they weren't allowed to use them on the premises, but they wanted to incorporate shelter. They also had meals every breakfast, lunch, and dinner. They also had case managers, medication monitoring, and transportation. And we worked with this non-for-profit with my school, where we would come in once a week with a group of classmates. I think we had maybe 5 or 6 of us each time. And we would do group therapy with the people living there. We would do like nutrition education, return to work education. We would do discussion on, because we had a lot of people with schizophrenia and psychosis too. And just, it's so eye-opening hearing the women's stories talking about their experiences with prostitution to buy drugs. And it's just so, you realize like, wow, this is such a different world than suburbia in Missouri.
Yeah. Well, it's just figuring out the role of OT in those settings. I think, I don't know, it probably depends on your school. My school was pretty heavy on mental health at the time. I think our director, what do you call them? The director of the
program
director. She had, her emphasis was mental health. And so we had a lot of mental health. So I just think like you have it in school, and I had such a perception. And I mean, I totally smashed all my perceptions of who I was and what we are in those different settings and what our role is as an OT. I think it was such a learning experience for me. And I'm sure everybody has, I don't know. It's just like one of those kind of things that really honestly shaped me. Like it really did.
Yeah, it's such an important semester for OT programs. And I would love to hear your experiences in the comments on the website. Yeah.
Let us know where you did your mental health, or if you're working in mental health, what type of setting. Because I'd love to hear that. That stuff is so cool.
And it's interesting. I'm learning a lot from occupational therapists, not in the U.S. A lot of them have mental health careers, and it's such a low percentage in the U.S. So I would love to see it kind of become more prevalent in the U.S. I think I read somewhere that it's a very small percentage in the U.S. for mental health. So
in occupational therapy?
Yeah.
Well, I mean, let's be honest. There's so much that goes into that. It's partly, defining our role, but the other thing is like the reimbursement is so terrible.
Right.
And it's the healthcare system. And so like, I even had like one mental health, like when I was doing, even as a student. And I mean, honestly, this is probably 16, 17 years ago. Like me and one of my friends, we were going to go to this other city, and I was going to do my physical disabilities, and she was going to do her mental health. And then it got canceled because they're like, oh, we just closed the unit down. And you're like, oh my gosh, wow. Where are those people going to access that? To access those services. Yeah. But I don't know. I mean, that's a whole nother podcast episode.
I know.
In its own.
Part 2 coming soon.
Yeah.
But really, I wanted to talk about this topic with the recent kind of media coverage on the 2 suicides that are out in public, even though there are suicides every day happening. But with the Kate Spade and Anthony Bourdain suicides happening within days of each other, it's interesting to see just how much it's covered, depression and suicide in the media. And just with the Anthony Bourdain suicide, just him being my hero for the last 11 years, just watching him for literally a third of my life. Like, we have to cover depression and suicide. And especially with older adults, it's so much more common than I thought.
Yeah. I mean, if you look at the statistics, they say something like, I'm talking about older adults. So they classify older adults, like the National Institute of Aging classifies it over anyone 65 years of age and older. And so they say like over, 2 million people in the US over the age of just 65. So, we're just talking about older adults have some form of depression. That is a large statistic. It's a large statistic. And I don't know. It's just, I think the whole topic, it's so important to talk about because especially as healthcare practitioners, I feel like it becomes a little bit normal-ish or not at all. I think what's hard is when I was trained as an OT, back in the day in school, it's you have your mental health settings and you have your physical disability settings. And maybe we did, but I don't really remember learning a lot about how to integrate some mental health or, even addressing it more in the physical disability areas, like acute care.
It's so prevalent in acute care and inpatient rehab, subacute, home health. And I feel the same way. I feel like I'm trying to learn now, just with courses on continuing ed on how to use that therapeutic use of self with people that are exhibiting signs of depression, and how do I actually work with them with that, because it's so important for us to address not only the physical, but also the mental.
I mean, I'm just kind of thinking about myself and my own practice. And I honestly don't, that's not part of my initial assessment. I'm not saying necessarily go through a whole depression assessment, but I don't actually, it's one of those things you have to actually make an effort to add in, I think, from my experience, same with sexuality or it's not part of our typical, assessment or evaluation form. It should be just as a check, bring it up as a normal conversation, because we're trying to address the person holistically. And why aren't we in these physical disability settings talking about that? Or maybe it is, and maybe it's just some of the places that I've worked, or because we're so focused on, reimbursement, and you have okay, we need to, fill out the FIM, we need to fill out the modified Barthol so we can get our G codes or get whatever it is, and that's kind of not part of it. Is that?
There's so many other components, and it's not just occupational therapists, because I'm on this research site right now, and it says primary care physicians accurately recognize less than 1/2 of their patients with depression, and more than 55% of older adults treated for mental health received care only from their primary care physicians, and less than 3% of them received treatment from mental health professionals, which is crazy to me.
That's crazy.
That it's just not addressed.
Well, I think sometimes it's not addressed, and or if a patient honestly says something about it, I feel like it's not really addressed. It's not okay.
Kind of brushed under.
Yeah.
We have to look at your cardiac functioning in the doctor's office.
Right. And so maybe, here's an example. I can think of an example. You're working with a patient, maybe you don't address it in your evaluation, it just doesn't come up. Okay. And you're working with someone, and then someone makes a comment about being depressed or suicidal ideation, or I just wish, God would just take me now. I don't know about you, but I don't know, working in long-term care, how many times I've heard that. And so you document it, you tell the social worker, and then you feel okay, I've done my role. But have you done your role? Is that our role? Is our role just to be someone brought it up, let's pawn it off? And I'm not saying we can't necessarily, we need to, everyone has their role, but if someone's going to say that out loud to you, they're
asking for help.
However that may look. It's crazy. And there's huge statistics on people who have, depression after a stroke, as an example, and if you guys have, I don't know if anybody's listened to the Seniors Flourish Podcast episode with Alex Terrell. She's a rehab psychologist from the University of Utah, and her team and her OT students that she works with is doing research on resilience after a stroke. So what are some things that you can work on? Because a lot of people have depression. So not only does the patient have depression, but the caregiver or care partner has, they're going through the whole grieving process and trying to figure it out. And she gives lots of ideas on things that they've shown that works, positive affirmations, and, she gives a big list. So check that out. But I guess what I'm saying is, those are the things that we need to be vigilant about. I mean, even if it's not like the focus in physical disability settings, hospital settings, but like it needs to be not only just like, it doesn't even have to be this big thing, but you can have this conversation being like, hey, how are you feeling today? Or, I don't know, like I'm looking. So, I mean, what else? What other settings?
Well, in any of the settings too, you can even if you don't hear directly from the patient that I'm feeling this way, you can also look for signs.
Yeah, exactly.
Like a change in eating habits, change in sleeping habits, and sadness are the 3 most common signs according to Mental Health America.
Yeah.
But just kind of keeping your eyes peeled for, especially when you know the patients, if they're in a long-term care setting and you know them and you recognize that they're acting a little bit differently.
Yeah. But I think
inpatient rehab is different, from week to week.
Oh, and the thing is I start getting on my soapbox, but like the thing about it is I feel like people just kind of assume that it's a normal, quote, normal part of aging, and it's not. Just because you're getting older does not mean that you're just going to naturally, be depressed. And I feel like sometimes it's like those things, it's like saying like, when people get older, they just get really weak. And that's actually not part of aging. Like your mental health, your health of your brain is so important. And I just feel like we really need to advocate for our patients and making sure that they're getting the services they need. Because I mean, it is depressing if you get, if you feel like you're being, quote, stuck in a long-term care facility, or you're in inpatient rehab because you had a stroke, or you're progressing in some disease process. Like that's a lot to process.
A lot to take in.
Yeah. And I mean, it's our responsibility to make sure that our patients are being addressed as people. I mean, they're not just a diagnosis, and we need to look at look at their lives and them holistically. It's just, and
using that therapeutic use of self, just with the active listening, it just can go a long way, especially in acute care. People, when I talk to them, even just with evaluation or treatments, I may be the only person that's actually listened to them all day. You have 20, 30 people coming in and out all day, but just they don't have anyone to hear them out. So if you're in a fast-paced setting like that, you can still provide intervention.
Yeah. Yeah. Oh, I know. I think sometimes those little things are such good reminders. I mean, we all know that as OT practitioners that this is something we should be addressing. But I think sometimes you're just like, yes, I haven't been addressing that like I should. But there are some, depression scales, like you were saying, Sarah, like those patients that you kind of know, or because you've been working with them for a long period of time and their mood changes, or some of those other signs of depression, even if they don't verbalize it. And, there's no reason why you can't like literally crack out like I'm trying to think of, there's a OT assessment. Oh, the Geriatric Depression Scale, the GDS. And, it's just, you ask,
which is free and online.
Yeah. Free online. They actually now have an app you can do on your phone. iPhone and Android. And so you don't have to interpret results or anything, but basically you ask them a bunch of questions. And if the patient scores higher than 5, they should be referred to some sort of, counselor, mental health, psychologist, social worker, whatever setting you're in and whatever setup to refer to the physician or whatever, to have that looked at more, addressed.
And it's really easy. It's only 1 page and it's free. So it's no matter what setting you're in, you can just download it. It's 1 page of yes and no questions. So it will take you not very long to administer. And it's just really great to have that actual assessment and tangible information to be able to document too, so that you can share that with other healthcare providers.
Yeah, for sure. I think it's just, I can't imagine over the years, I struggled with depression as well. And it's like one of those things like, people aren't always going to always just reach out and tell you that they're feeling terrible. And so like being able to pick up on those signs and like you said, using your therapeutic use of self to listen and listening to your patients, because that's the most important, listening to what they're actually saying and, just finding the services that they need. It's just, it does take,
So crucial.
Yeah, it's crucial. It takes a little bit of experience and just listen to your patients. And then also, I actually also think that, depending on your setting, making sure that you, like you were saying, Sarah, like have that depression scale, maybe in a clipboard if you're walking around anyway. Like how hard is that?
Yeah.
Or having like, even like the National Suicide Hotline, like having that accessible or just having some of that information. Because sometimes honestly, like, I've known in the past, I've told patients like, we really need to talk to the social worker about this and get the services you need or refer to your physician. And I just want to make sure that you're safe and trying to think of those and even having some key phrases that so you feel comfortable with that. And sometimes they don't want to, and they're right. But also it's our responsibility to document that and also notify the correct people and then give them the resources they need. Do they need the suicide line? Do they need this is your physician, this is the psychologist or the hospital or whatever setting you're in, but just making sure they have the resources they need and that they're being heard.
And even just a final note on that, even educating your patients on depression, because this Mental Health America survey found that 68% of adults over 65 know little or almost nothing about depression. So they may not know about their feelings.
Yeah.
So educating on that too is a great way.
Yeah. You may say like, oh, are you feeling depressed? They're like, no, but they're showing like all the signs. Yeah. And I think what people like, there's such an old perception of what someone that is depressed looks like or acts like or is, and what the reality is they're two completely different things. So yeah, education is perfect. So I think we'll put in the show notes all the information about the geriatric depression scale and the hotline, and just some links for you to be educated on that. So thanks, Sarah, for talking about this. I think you're right. Like just so much is going on. It puts it in the forefront, but it's something that we need to talk about all the time.
Yeah, especially just keep all of your mental health information that you learned in school, keep it in the back of your brain, because as the years go on and you get more focused with productivity and the FIM scores, just really remember that we do have so much background in the mental health realm and that we should be addressing it throughout our careers, regardless of the setting.
Yeah. Perfect ending. All right. Well, thanks, Sarah, for the Betweenisode.
Thank you.
All right. And thanks everyone for listening.
Thanks for listening.
Yeah. Do you feel like you're navigating the OT world without a map? Not feeling confident or competent in your day-to-day treatments and struggling to apply your knowledge clinically? Then be sure to check out the Seniors Flourish Learning Lab membership. It has all of the treatment ideas, patient handouts, clinical resources, community support, and mentorship you need to succeed. Join today at seniorsflourish.com/learninglab.